So what exactly is bracing for scoliosis and what different bracing options are there? Hey, I'm Dr. Chris Scoobles and I want to talk to you about when we use bracing for scoliosis and how different braces actually work differently and have different goals for how they treat scoliosis. So scoliosis is when someone has a lateral bending of at least 10 degrees with rotation of the spine. And in moderate and more severe scoliosis, especially when the curves progress beyond 25 degrees, then bracing can be a very effective and a lot of times the most effective non-surgical treatment option available. Now, the goal of bracing is essentially to keep the curve from progressing to surgical levels. And this is done in a few different ways. Now, a lot of braces and traditional braces, like the ones that are usually prescribed in orthopedic centers and hospitals, the main goal of those types of braces is generally just to try and stabilize the spine and keep it from progressing. They use something known as three-point pressure system, where basically it squeezes the spine and puts pressure on it, kind of like a cast, and the goal is to hold it there and hopefully just try to keep the curve from progressing to surgical levels. They're not typically designed to try to make improvements of the curve, and if they do, those curve improvements are typically pretty mild, if any improvement at all. However, some braces, and especially more modern braces, they actually work to not only try and reduce the curve from progressing to surgery, but they work to actually improve and correct the scoliosis by reducing the size of the scoliosis. And instead of just squeezing the spine, modern braces, such as like the ScoliBrace, actually puts the spine in an overcorrected or corrected position and thereby influencing how the curve progresses and grows over time. So the biggest differences between traditional braces like a Boston brace, those braces are designed to try and hold the spine in position by squeezing it using three-point pressure system. Whereas modern bracing like the ScoliBrace not only wants to reduce the progression of that curve to scoliosis, but in many cases correcting the curve or reducing the size of the curve by putting the body in a 3D overcorrected position. Now, some things that are important to consider when looking at a brace, probably the most important is the effectiveness. It's like, how effective is the brace at improving the curve or reducing the curve's likelihood of progressing to scoliosis? So most important is the effectiveness of the brace. But for a brace to be effective, a person has to be able to wear it. So how easy is it for the patient to use? You know, a lot of braces are actually put on where they fasten in or strap up in the back. And if a patient has a brace that fastens in the back, it can be very difficult for the patient to don the brace or to put the brace off and on. If the patient can't put the brace off and on easily, they're probably not going to be very compliant. If they're not very compliant, the brace is not going to be effective. Other braces can require people's assistance to put the brace on because they can have a lot of straps and things like that. Some braces like the spine cord brace, which is actually a soft brace, can be very difficult for a patient, very time consuming for a patient to put off and on. So if you have a child or an adolescent wearing a brace and they're in school, they have to take the brace off to go to the bathroom, then it's a lot of work to put the brace back on. They're probably not going to be that compliant with it. And if they need someone to assist them putting the brace on, if they don't have that person there to assist them, they're probably not going to put the brace back on if they ever have to take it off. So it needs to be easy to use. Also, it's how comfortable is the brace to wear. If a brace causes a lot of pain or discomfort, the patient's not going to be compliant. So it has to be easy to use, and the patient has to be able to wear the brace for the prescribed time frame. And a lot of times in growing adolescents, the braces are prescribed to be worn full time or 23 hours a day. If a brace doesn't feel very good and it's very painful, then it's not going to be worn. On that flip side, I have seen people with braces, and the person that made the brace as comfortable as it could possibly be, but they made the brace to actually form or fit their scoliosis in a bad position. The problem with that is if it's designed around them in a bad position, it does nothing to actually change how that curve progresses or correct the curve. So yes, the brace needs to be comfortable, but it also has to be effective at the same time. So how the brace is designed, its effectiveness, and the ease of patient to use the brace, and the comfort of the patient wearing the brace are all things to consider when we're looking at different types of braces. That being said, let me talk about some specific braces and some of the most common braces. The first one I'm going to talk about is the Milwaukee brace. The Milwaukee brace was first designed in Children's Hospital in Milwaukee, Wisconsin, hence the Milwaukee brace. And it was designed, I believe, in 1945 or in the 40s. Now, this brace is not used very often anymore, but sometimes you'll still see it used for a high thoracic scoliosis. This brace has metal rods in the back and the front, and it's strapped on by the straps, and it has parts going all the way up to the neck and to the chin. And it can be very uncomfortable for bracing, and it's really like almost barbaric when you look at it, but sometimes these still are used, but they're not used that much anymore, and they're really not that effective. The number one prescribed brace, just by numbers, is what's known as the Boston brace. And the Boston brace it's a hard shell brace, but it is not a custom brace. Basically, it's a brace taken off a shelf. Sometimes it'll be measured for size, but it's not really custom made in a 3D manner, but it's a brace that is made, and then you have an orthotist. It's an off-the-shelf brace where an orthotist takes a standard brace and after the fact tries to make modifications to it, putting in pads and things like that to make it more custom for the patient. Now, Boston braces in the past were actually fastened in the back of the spine. More recently, they're starting to fasten them in the front because in the back they're just not effective. One of the problems with Boston braces, they actually work to reduce the curve in the lumbar spine. You need to have a normal curve. If you reduce that curve, it can cause a lot of problems, including pain, and impact how the spine grows and develops. And in many studies that have been presented at research conferences, when you compare a Boston brace to a more corrected or overcorrected 3D brace, the results frequently are much less effective with the Boston brace. Now, more modern brace, and the brace that we prefer to use is the ScoliBrace. And the ScoliBrace is different for several reasons. One, this is a true customized brace. It is made by using CAD/CAM technology, which is computer-aided design and computer-aided manufacturing. A provider will do 3D images of the spine, take some digital photos and x-rays, and they send those down to an engineer in Australia. And they work with the engineer to design a custom brace for the patient. And the provider's job is to gather the data and tell the brace designer, this is what I would like the brace to do. This is the patient's primary concern, whether it's pain, whether it's their aesthetics, whether it's risk of progression. And then with that information, they will custom make, design a brace, and then it's manufactured in the US and it's shipped to that patient, or shipped to the office so the provider can give it to the patient. Because it's custom made, it is designed to fit the patient perfectly. We're not taking a brace off the shelf and afterwards trying to make all these crazy modifications to try and then make it fit the patient's scoliosis. It is custom made to fit their unique body and their unique scoliosis, so it's much more effective. The second thing is, it doesn't work by squeezing the spine. It actually works by putting the spine in a 3D corrected position, and many times overcorrected. Scoliosis is a 3D spine deformity where it's bending and rotating, so the ScoliBrace puts the patient back in an opposite position, creating true 3D correction of the spine. It also is strapped on from the front, so it's very easy for the patient to put on and on their own, and they're designed to be comfortable but still create the maximal benefit, maximal correction for the patient. Now, to understand how the ScoliBrace is superior to traditional braces is to understand how the spine grows over time, especially in an idiopathic growing spine. So when someone is growing, when their growth plates are not sealed, and when you put pressure on a growth plate, it stunts the growth. So what happens is when you put pressure on a growth plate, the parts of the growth plate that have pressure on it grow slower than the parts that don't have pressure. So if you have a lateral bending of the curve, the inside of that curve has pressure, the inside of that spine will grow slower than the outside, and the spine will actually grow in an asymmetrical fashion. When someone's done growing, we cannot change the shape of those vertebrae. However, if we have someone that's still growing, especially in the earlier parts of growth, and they have a curve in their body, using the ScoliBrace, we can put their spine in an overcorrected opposite position. And when we put them in the opposite position, we are reversing those pressures on the spine and reversing the pressure on those growth plates. When we do that, the parts of the spine that had more pressure before have less pressure afterwards. And the parts of the spine that had less pressure before have more pressure. By doing this, we impact how the spine grows, and we allow the spine to grow in a more corrected position and reduce or correct the size of that curve, or potentially even reducing or correcting the entire curve. This is why a true 3D overcorrected brace is superior than a standard off-the-shelf brace that's designed to just try and squeeze the spine in position. It's because how the spine develops over time and how the brace is designed to work with the body to allow the body to grow more corrected. Some of the things we look at when we're designing these braces, we look at how, one, the patient's goals. Is it to reduce pain? Is it to improve aesthetics, to reduce the size of the curve, or prevent progression? All those things are considered. We look at how flexible the spine is. For example, if we have an adult that's very stiff and very rigid and they have no mobility in their spine and it doesn't bend or move, that brace will be designed different than a brace where we say we have a 12-year-old girl who's very flexible, very bendy, or even say a 25-year-old girl that's done growing, or female that's done growing, but they still have a lot of flexibility. Based on the severity and rigidity of the spine, we're going to design that brace different. That's where it gets truly customized to their individual goals, but also to their body, so they get the right brace specifically for them to greatly enhance the overall success rate and patient satisfaction. So a few tips for effective bracing, regardless of which brace that you get. One, you have to wear it. There was a landmark study called the brace study, and this is where the authors looked at the effect of bracing, and they had the patients divided into two different populations. In the treatment group, they actually got scoliosis braces, and then in the control group, they didn't get any braces, and they watched them over time. But the brace actually had to be stopped, and the study lost their ethics approval, and because the bracing group was overwhelmingly so obviously more effective than no treatment and reducing the likelihood of the curve from progressing to surgery, it was deemed unethical to not give the control group a brace. So there's two big factors when we're looking at bracing, especially in adolescents, to determine if it can be successful. One, when a patient's wearing a brace, there has to be correction in the curve with the brace on. So if a patient you have a 12-year-old girl, it's a 40-degree curve, without the brace on, when they put the brace on, that curve has to reduce. Typically, we want this to reduce by at least 50%. If with the brace on, the size of that curve does not reduce, that means either one, that the brace is not designed properly to be effective, the brace won't work, or two, maybe they have a spine that's actually not braceable. The second thing, the patient has to be compliant. If you have a patient that has a braceable spine and they have a perfectly made brace and they don't wear it, the brace is still not going to be effective, the treatment is not going to be effective. In that brace study, the authors found that the patients on average had to wear the brace a minimum of 13 hours for those teenagers' treatment to be effective. And they weren't even looking for correction, they were just looking at it to try and not progress the surgical levels. So two, the patient has to wear the brace. The brace is dose dependent. So first thing is, get the right treatment, get the right brace, follow the treatment, and get the results you're looking for. So if you're finding this information useful, like, follow, or subscribe, and share with others you think would benefit from this information. And if you have scoliosis or you have a child that has scoliosis, don't hesitate to reach out. Just give our office a call and ask for a free consultation to see if there's something we can do to help you.